lot of people think that heart failure is a disease, and in and of itself it kind of is, but it's really not what we call a specific disease, because it's not something where the symptoms are the same every single time for every single person who's going into heart failure. So that's why this slide is saying it's not a specific disease. However, what it is a complex clinical syndrome that results from any functional or structural impairment to the heart. Specifically, the ejection of blood or ventricular filling. The heart becomes unable to pump the blood in sufficient amounts from the ventricles to meet the body's metabolic needs. So the symptoms depend on the cardiac area that's affected. With left-sided heart failure, we get pulmonary edema, coughing related to that edema, shortness of breath, and dyspnea. Remember, dyspnea is difficulty breathing. With right-sided heart failure, we get systemic venous congestion, pedal edema. Remember, pedal means your feet. Jugular venous distension. We've got blood backing up on the body side of the heart. So on the venous side of the heart, so the jugular vein is distended. We get ascites. Ascites is fluid in the abdomen, and we get hepatic congestion. There's a number of reasons why heart failure happens, and myocardial infarction is one major one. Pulmonary hypertension is another one. Coronary artery disease, valvular insufficiencies, infection, anemia. Really think about how anemia may cause heart failure. In some cases, thyroid disease can cause it. So think about these different causes and how that would affect, whether it would be affecting the right side of the heart or whether it would be affecting the left side of the heart. We've gone over the conduction system of the heart both in pathophysiology and previously in one of the previous lectures. So I'm not going to spend a lot of time with this, just to say that the conduction originates in the SA node, or the sinoatrial node, and then it is taken down the internodal pathways to the AV node, or the atrial ventral node, and from there it goes down the branch bundles into the Purkinje fibers, and that's where the contraction begins. And that, like we heard in the video the other day, it's kind of like a tube of toothpaste, in that the bottom part of the heart squeezes first and pushes the blood from the bottom of the heart up through the valves, and either it's going into the lungs or it's going into the body. The American College of Cardiology and the American Heart Association has set various criteria to stage heart failure. In stage A, you're at high risk for heart failure, but you don't have any symptoms and there's no structural heart disease. So think about the people that would be at high risk for heart failure but don't have any symptoms yet. Perhaps somebody with diabetes, perhaps somebody that has some mild anemia. So you kind of get the idea, or somebody with hypertension. So you have a general idea of somebody who is at risk, but they don't have it yet. In stage B, you have structural heart disease, but you don't have any symptoms. So this might be somebody that has a valvular regurgitation, or it may be somebody that has a mitral valve prolapse, something like that. So they have a structural disease of the heart, but they don't have any symptoms of heart failure yet. With stage C, there's structural heart disease and symptoms. And so once you start having symptoms, then you should be starting to treat those symptoms. In stage D, you have refractory heart failure that requires interventions. So this is somebody that is no longer at home. They are coming into the hospital because they are sick and need to have interventions done. The drug therapy for heart failure includes positive inotropic drugs. That increases the force of the myocardial contraction. We also give positive chronotropic drugs. Remember, inotropic increases the force of the contraction. Chronotropic increases heart rate. Dromotropic drugs accelerate the cardiac conduction. So it improves the conduction of the electrical activity in the heart. Loop diuretics like furosemide, which is also known as Lasix, are also used to reduce the symptoms of heart failure that's secondary to fluid overload. So remember, with left-sided heart failure, you have pulmonary edema. So we give Lasix to help absorb that liquid, that fluid, into the bloodstream again and be able to urinate it out. Also, with right failure, we have edema in the periphery of the body, and so it helps us to lose that extra fluid that is sitting on the venous side of the body. Aldosterone inhibitors like spirulactone, eplerenone are added as the heart failure progresses. And only after we've tried all these other drugs do we add digoxin. The drugs of choice for early treatment of heart failure include ACE inhibitors. So if you have somebody with early heart failure, then we're going to see lisinopril or captopril or some other type of ACE inhibitor given. ARBs may be given if they don't tolerate the ACE inhibitors, so valsartan, losartan, candesartan. Notice how these ARBs end with sartan. Certain beta blockers like metoprolol, which is a cardioselective beta blocker, or Carvedal is also a non-specific beta blocker, but it's specific for heart disease. So you would look for those LOLs, again, with your patient that may have heart failure. Dobutamine is a positive inotropic drug, and it is given by IV infusion. So this would be somebody that's being treated in the hospital that we're trying to improve their cardiac conductivity. So we want that heart muscle to be stronger. So we're going to give them dobutamine for that. Hydralazine and isosorbidate dinnerate, or Bidil, is one of the first drugs that were approved for a specific ethnic group, because they found that in African American populations, this combination drug worked much better than some of the other drugs that they were giving them. Talked about these various antihypertensive medications when we were talking about hypertension. So I'm not going to spend a lot of time with them, but we'll just pick up and talk about some of the main things that these do. With the ACE inhibitors, they prevent sodium and water resorption by inhibiting aldosterone secretion. Diuresis results, which decreases preload, or the left ventricular end volume, and that in turn decreases the work of the heart. Examples of ACE inhibitors include lisinopril, enalapril, fosinopril, quinapil, captopril. You get the picture. Lisinopril has uses for hypertension, heart failure, and after acute MI. The side effects include hyperkalemia and a dry cough. Adverse effects are related to the effect of aldosterone on the kidneys and can result in decreased renal function. Angiotensin II receptor blockers, or ARBs, are potent vasodilators. They decrease systemic vascular resistance, or afterload. They're used alone or in combination with other drugs like diuretics in the treatment of hypertension or heart failure. Examples of these drugs are valsartan, candesartan, eprosartan, irbesartan, telmisartan, olmesartan, and losartan. And again, remember these drugs end with sartan, and that's how you can remember that they're ARBs, or angiotensin II receptor blockers. Valsartan shares many of the same adverse effects as lisinopril. ARBs are not as likely to cause the cough that's associated with the ACE inhibitors, and they're not as likely to cause hyperkalemia. So often these are things that you may want to give if somebody is more prone towards hyperkalemia. As we've mentioned before, beta blockers have a cardioprotective quality. They do that by preventing catecholamine-mediated actions on the heart and by reducing or blocking sympathetic nervous system stimulation to the heart and the heart's conduction system. Metoprolol and carvedilol are two medications that are specifically used with heart failure and after an MI. So I just want to remind you with the aldosterone antagonists that these medications act against aldosterone. Spironolactone and epinephrine are useful in severe stages of heart failure. The way it works is that when there's activation of the renin, angiotensin, and aldosterone systems, it causes an increased level of aldosterone. That then causes retention of sodium and water, and that leads to edema that can worsen heart failure. So what these drugs do is they act against aldosterone. So you might say, well, why is that an issue anyway? Well, renal hypoperfusion occurs as a result of reduced cardiac output, and that results in the activation of the renin-angiotensin-aldosterone system, which compensates for the hypoperfusion. However, this contributes to the pathology of heart failure, among other actions, increasing the release of aldosterone. Aldosterone has been shown to cause coronary inflammation, cardiac hypertrophy, myocardial fibrosis, ventricular arrhythmias, and ischemic and necrotic lesions. There are currently just the two aldosterone antagonists commercially available in the United States, spironolactone and epinephrine. Spironolactone is a non-selective aldosterone antagonist. It also is a potassium-sparing diuretic. So if you think back to the other diuretics like furosemide, furosemide will cause you to have to urinate out your potassium. So spironolactone will keep that potassium in there in your system so that you don't have to take potassium supplements. And it's antagonistic action against aldosterone has been shown to reduce the symptoms of heart failure. Epinephrine is selective to the aldosterone receptor. So in other words, it makes it so that aldosterone cannot attach to the receptor. It fills in that space. And so that's how it is a selective aldosterone blocker. It blocks it in the kidney, the heart, the blood vessels, and the brain. So we've already mentioned these two, what they call miscellaneous drugs that are used to treat heart failure. Bidil or hydralazine combined with isosorbidide dinitrate is the first drug that's been approved for a specific ethnic group, namely African Americans, and it acts as a antihypertensive. That's what the hydralazine does, and it's also what the isosorbidide dinitrate does. The dobutamine is a beta-1 selective vasoactive adrenergic drug, and structurally it's similar to dopamine, but it has less of the alpha problems with it as dosages need to increase than the dopamine does, which is why it's utilized in heart failure. The B-type natriuretic peptides, I want you to look at this word. We have Na, which is the chemical symbol for sodium, and uretic, meaning having to do with urine. So we have sodium in the urine peptides. It includes natriuretide, which is Natricor, and it's a synthetic version of the human B-type natriuretic peptide. It causes vasodilating effects on both arteries and veins. The effect of natriuretide is diuresis, so we have urinary fluid loss. We also have natriuresis, or urinary sodium loss. Again, think about how these words are put together. It's going to help you to remember what the effects are with them. So when you see this word as natriuretic, you're going to say, oh, that means that there's sodium in the urine. It also causes vasodilation, and it has an indirect increase in cardiac output and suppression of neurohormonal systems like the renin-angiotensin system. When we look at the adverse effects that are related to the B-type natriuretic peptides, we have to remember that this particular medication is used in the intensive care setting as a final effort to treat severe, life-threatening heart failure. and it's often used in combination with several other cardiostimulatory medications like dobutamine, like digoxin. So the adverse effects that are associated with it includes hypotension. Remember, we've got vasodilation that's happening with this medication. So when you have vasodilation happening, you have hypotension. It can cause dysrhythmias, headache, abdominal pain, and insomnia. So our first question, which patient is the best candidate to receive nasiritide therapy? A patient with arterial fibrillation who has not responded to other drugs, a patient needing initial treatment for heart failure, a patient with reduced cardiac output, or D, a patient with acutely decompensated heart failure who has dyspnea at rest. Well, the answer to this one is D. We're looking at the patient who is in the most difficulty related to their heart failure. At this time, nasiritide is generally used in the intensive care setting as a final effort to treat severe, life-threatening heart failure. It's often used in combination with several other cardiostimulatory medications. The manufacturer recommends that nasiritide not be used as a first-line drug for this purpose. In 2005, an expert panel reviewed nasiritide at the request of the U.S. Food and Drug Administration and in response to reports of worsened renal function and mortality. The expert panel stated that the use of nasiritide should be strictly limited to the treatment of patients with acutely decompensated heart failure who have dyspnea at rest. It should not be used to replace diuretics and should not be used repetitively or to improve renal function. Phosphodiesterase inhibitors work by inhibiting the enzyme phosphodiesterase. It results in intracellular increase in CAMP. CAMP stands for cyclic adenosine monophosphate. It's a derivative of adenosine triphosphate, or ATP. It's used for intracellular signal transduction, such as transferring into cells the effects of hormones like glucagon and adrenaline. It results in the medication results in a positive inotropic response, and it will also result in vasodilation and an increase in calcium for the myocardial muscle contraction. One of the things that, because of the vasodilation response, it may require the administrations of fluids prior to giving it. Inodilators, like inotropics and dilators, need to be given in a highly monitored setting for the treatment of myocardial dysfunction with increased systemic or pulmonary vascular resistance. The phosphodiesterase inhibitors are for the short-term management of heart failure in intensive care units. The American Heart Association and the American College of Cardiology advise against long-term infusions of the phosphodiesterase inhibitors. Milrinone is the only available phosphodiesterase inhibitor. Milrinone is available also only in an injectable form and is usually given as a drip. The adverse effects include cardiac dysrhythmias, headache, hypokalemia, tremor, thrombocytopenia, and elevated liver enzyme levels. It has interactions with a number of drugs, but with diuretics, it has an additive hypotensive effect. With digoxin, it has additive inotropic effects. Cardiac glycosides are no longer used as first-line treatment. They found that it does not reduce mortality. Originally, the cardiac glycosides were obtained from the digitalis plant, also known as foxglove. Digoxin is the prototype of cardiac glycosides. It's used in heart failure and to control ventricular response to atrial fibrillation. The mechanism of action for cardiac glycosides is that they increase the myocardial contractility. In other words, they make the contraction of the heart stronger. They also change the electrical conduction properties of the heart. They decrease the rate of electrical conduction, which prolongs the refractory period, the time between the sinoatrial node and the atrioventricular node. So one of the side effects that we see with cardiac glycosides is a decrease in heart rate. The cardiac glycosides have a positive inotropic effect. They increase the force and velocity of the myocardial contraction without an increase in oxygen consumption. They also have a negative chronotropic effect in that they reduce the heart rate. They also have a negative dromotropic effect because they decrease the automaticity at the SA node and decrease the AV nodal conduction and some other effects as well. So what do these drugs do with our patient? Well, they increase the stroke volume. If you think about it, if we slow down the heart rate, that's going to allow for a longer period of time for the ventricles to fill. That means that, and then we've increased the contractility of the ventricle, so that means that we're going to have increased stroke volume. We have a reduction in heart size during diastole. We have decrease in venous blood pressure and vein engorgement because we're moving things along, and we have that increase in the velocity of the blood leaving the heart, so we have more velocity coming back into the heart again. We increase the coronary circulation because we have that increased pressure. We decrease in exertional and paroxysmal nocturnal dyspnea, cough, and cyanosis. So a lot of times with heart failure, people have more problems at night with dyspnea, and so this actually makes that better. And exertional means that anytime you're walking or moving, things that require energy, it actually decreases the dyspnea that's associated with that as well. We see improved symptom control, improved quality of life, and increased exercise tolerance. But the one thing that they're not quite sure of is, despite all of these benefits, why there doesn't seem to be any apparent reduction in mortality. Question number 2. A patient is in the emergency department with new onset atrial fibrillation. Which order for digoxin would most likely have the fastest therapeutic effect? Digoxin 0.25 milligrams PO daily, digoxin 1 milligram PO now, then 0.25 PO daily, digoxin 0.5 milligram IV push daily, or digoxin 1 milligram IV push now, then 0.25 milligrams IV daily. So if we look at these answers, we know that PO is going to be slower action than IV. So we can get rid of those first two answers right away because we want to know which is most likely to have the fastest therapeutic effect. If we give 0.5, and we're not giving any kind of loading dose, then it's not going to have its therapeutic effect as soon. Remember that whole half-life and how things slowly increase up to the therapeutic dose, and then it kind of varies slightly around that therapeutic level that you want it to have. Thinking back to how drugs in general work. So if we want to get a fast therapeutic effect, we're going to give this 1 milligram IV push now. That's going to give us a good increase in the amount of drug that's in the body. Then we're going to start giving 0.25 milligrams IV daily. So we don't have to go through the first pass effect. It's going to be in the system, and it's not going, this 1 milligram, its half-life is going to be a half a milligram. So by the time we get that second dose, we haven't dropped all the way down to nothing. We still have a little bit of drug in, and that 0.25 is going to take us up. So a digitalizing dose is often used to quickly bring the serum levels of the drug up to a therapeutic level. The IV doses would accomplish this much more quickly. What do we need to know as far as adverse effects of cardioglycosides? Well, digoxin, also known as lanoxin, has a very narrow therapeutic window. And if you remember back to those first chapters in pharmacology, when there's a very narrow therapeutic window, then we need to monitor drug levels because it doesn't take very much to get us outside of that window of therapeutic levels. Drug levels should be between 0.5 and 2 nanograms per milliliter. Low potassium levels increase the toxic effects of digoxin. So electrolyte levels need to be monitored closely. Cardiovascular-wise, they may have dysrhythmias including bradycardia or tachycardia. Bradycardia being the most common adverse effect. With the central nervous system, there may be headaches, fatigue, malaise, confusion, and convulsions. In the eyes, the color vision, or the ability to see green, yellow, and purple may be affected. They may get a halo vision. In other words, they'll see a halo around things. And they may see a flickering light effect. When they see that, that means it's at a toxic level. Gastrointestinally, they can have anorexia, nausea, vomiting, and diarrhea. Digoxin toxicity with digoxin immune Fab or digibind therapy can result in hyperkalemia, with serum potassium levels greater than 5 milliequivalents per liter in a digitalis toxic patient. This can cause life-threatening cardiac dysrhythmias and life-threatening digoxin overdose. Another question. A patient is receiving digoxin 0.25 milligrams per day as part of treatment for heart failure. The nurse assesses the patient before medication administration. Which assessment finding would be of most concern? An apical heart rate of 58 beats per minute, ankle edema of 1 plus bilaterally, serum potassium levels of 2.9 milliequivalents per liter, or D, a serum digoxin level of 0.8 nanograms per milliliter. So the correct answer on this is that serum potassium level of 2.9. The hypokalemia may precipitate digoxin toxicity, therefore it is of the biggest concern. The apical pulse is slightly under 60 beats per minute, but bradycardia may occur with digoxin therapy and the heart rate should be monitored. Now personally, I frequently have a heart rate of less than 60 and I'm not on digoxin. The ankle edema may be a manifestation of the heart failure and not a new concern. And the dig level is within the normal range. So you can see why we would choose the serum potassium level. Some of the conditions that may predispose to digoxin toxicity include hypokalemia, use of cardiac pacemaker, hepatic dysfunction, hypercalcemia, dysrhythmias, hypothyroidism, respiratory or renal disease, and advanced age. So let's talk now about some of the nursing implications. First of all, you want to assess the patient's history, their drug allergies and contraindications. Assess the clinical parameters including their blood pressure. Also make sure you take their apical pulse for 1 full minute. Check their heart sounds and breath sounds, weight, input and output, electrocardiogram, and their serum labs for potassium, sodium, magnesium, calcium, renal and liver function studies. This particular slide doesn't say anything about it, but it's important for you to know what a normal dose of digoxin in particular is for your patient. I had a situation, I wasn't there when it happened. I came to work at the hospital after the situation happened, but we had a nurse that floated to the NICU from the adult cardiac unit. And thinking that that matched up really well, they gave that nurse a baby that had a cardiac issue. And the baby was to receive a dose of digoxin. Well, the nurse was so used to giving digoxin to adults that she didn't think anything about the dose that she pulled up. So you've been seeing these doses of 0.25. Well, in babies, it's 0.025. So basically, when she gave this baby its dose of digoxin, she gave the baby 1,000 times more than he was supposed to get. And needless to say, the baby died. And from that point on in our unit, the medications were given by NICU nurses and not by the nurses that floated into the unit, which for most part, they didn't mind the fact that somebody else was giving medications. So before we give any one of the heart failure drugs, especially digoxin, we want to count the apical pulse for 1 full minute. For an apical pulse less than 60 or greater than 100 beats per minute, we hold the dose and we notify the prescriber. Now, obviously, these numbers are different if we're talking about children, because for a child, I wouldn't want to see their apical pulse at 60. I would want to see their apical pulse for an infant above 80, and the greater than 100 doesn't apply to them either, because their heart rates always are greater than 100. So we would be looking more at greater than 160 or greater than 180 for a neonate. And then for the different age groups of children, we would be looking at a different number. You want to hold the dose and notify the prescriber if the patient experiences signs or symptoms of toxicity like anorexia, nausea, vomiting, and diarrhea, or visual disturbances like blurred vision, seeing green or yellow halos around objects. Obviously, for nonverbal people, including the elderly and the infants, or people just in general that are nonverbal, you're going to have to look more at the nausea, vomiting, and diarrhea than these things that can be described to you. You want to check the dosage forms carefully and follow instructions for administering. Avoid giving digoxin with high fiber foods because fiber binds with the digitalis. Patients should immediately report a weight gain of 2 pounds or more in 1 day or 5 pounds or more in 1 week. That would be a sign that they're retaining fluid. Nasuritide or milrinone, you're going to use an infusion pump when you give it. You're going to monitor I&O, heart rate, rhythm, blood pressure, daily weights, respirations, and other things. And of course, we're going to monitor for therapeutic effects, which should be increased urine output, decreased edema, decreased shortness of breath, decreased dyspnea, decreased crackles when we listen to the lung fields, and decreased fatigue. We should also see resolution of paroxysmal nocturnal dyspnea, and we should see improved peripheral pulses, skin color, and temperature. And of course, we're going to monitor for the adverse effects that are specific to each medication. A dysrhythmia is any deviation from the normal rhythm of the heart. Antidysrhythmics are used for the treatment and prevention of disturbances in cardiac rhythm. So we've talked a little bit about the cardiac cells. Inside the resting cardiac cell, there's a net negative charge relative to the outside of the cell. This difference in electronegative charge results from an uneven distribution of ions, the sodium, potassium, and calcium, across the cell membranes, and we call this the resting membrane potential. The resting membrane potential is an energy requiring pump that's needed to maintain this uneven distribution of ions. And we call this the sodium potassium ATPase pump. The action potential is a change in the distribution of ions caused by the cardiac cells becoming excited. The movement of the ions across the cardiac cell's membrane results in an electrical impulse spreading across the cardiac cells. This electrical impulse leads to contraction of the myocardial muscle. We have the four phases that go from the sinoatrial node and the Purkinje cells that each have separate action potentials. For those of you that view things better visually, this talks about the phases of the action potential, from depolarizing to depolarize to repolarizing, the sodium-potassium pump, activating, and then the resting phases. So I'll let you figure out this one here. It's also in your book, and we'll move right along. These pictures are looking at the action potentials. We look at it from the SA node and the Purkinje fibers, also as membrane potential. And you can see the action of sodium and the action of calcium and potassium on these action potentials, and where they are as far as the phases, phase 1, phase 2, phase 3, and phase 4, from the different angles. So here we're looking at the ECG, or some people call it EKG. That comes from the German. And since we don't speak German generally, we call it an ECG. Initially, we see the P wave. From the beginning of the P wave to the beginning of the R wave, we call that the R PR interval. Then we have the QRS complex, which is the big spike in the middle, and we call that the QRS interval. And then we have the ST segment, which is the area between the S, where the S starts and where the T ends. And finally, we have the T wave, which is that little wave after the QRS. You can see that between where the Q starts and the T ends is the QT interval, and that gives you the general view of a normal ECG. Common dysrhythmias include supraventricular dysrhythmias, meaning that the electrical conduction is coming outside of the ventricle, above the ventricle. The ventricular dysrhythmias, the ectopic foci, which means that it's coming from somewhere else in the heart from where we expect it to come. And then we have conduction blocks, where the electrical conduction doesn't flow through where it ought to go. Antidysrhythmic drugs are classified using the Vaughan-Williams classification, and it's based on the electrophysiologic effects of a particular drug's on the action potential. So we have the class 1A, 1B, 1C, we have the class 2, class 3, and class 4 drugs. And we'll talk about each one of those. In the von Williams classification, let's look at the mechanism of action. The class 1 drugs as a whole are membrane stabilizing drugs. They act on the fast sodium channels and are normally fast sodium channel blockers. They're divided into 1A, 1B, and 1C drugs according to their effects. The class 1A drugs, which include procainamide, quinidine, and disopyramide, block the fast sodium channels. They delay repolarization and increase the APD. They're used for atrial fibrillation, premature atrial contractions, premature ventricular contractions, ventricular tachycardia, and Wolff-Parkinson-White syndrome. Procainamide is used for atrial and ventricular tachydysrhythmias. There is a significant adverse effects associated with this drug, including ventricular dysrhythmias, blood disorders, systemic lupus erythematosus like syndrome, nausea, vomiting, diarrhea, fever, leukopenia, macular papular rashes, flushing, and torsades de pointes, resulting from prolongation of the QT interval. Contraindications include a known hypersensitivity, heart block, and systemic lupus erythematosus. Class 1B is phenytoin and lidocaine, and they block the sodium channels. They accelerate repolarization, they increase or decrease the APD, and lidocaine in particular is used for ventricular dysrhythmias only. Phenytoin is used for atrial and ventricular tachydysrhythmias caused by digitoxicity or long QT syndrome. Phenytoin is also used as an anti-seizure drug, so you'll be seeing this drug again when we talk about the neuro drugs. Lidocaine, also known as xylocaine, raises the ventricular fibrillation threshold. It has significant adverse effects that include twitching, convulsions, confusion, respiratory depression or arrest, hypotension, bradycardia, and dysrhythmias. Contraindications in use include a hypersensitivity to lidocaine, severe sinoatrial or atrioventricular or intraventricular block, or Stokes-Adams or Wolff-Parkinson-White syndrome. Class 1C includes flecainide and propafenone, and they block the sodium channels, and they have a more pronounced effect than the 1A and 1B drugs. They have little effect on the APD or repolarization, and they're used for severe ventricular dysrhythmias. They may be used in atrial fibrillation or flutter, Wolff-Parkinson-White syndrome, and supraventricular tachycardia dysrhythmias. Flecainide is the first-line drug in the treatment of atrial fibrillation. It has a negative inotropic effect and depresses the left ventricular function. Adverse effects include dizziness, visual disturbances, and dyspnea. Think about the effect. If you're not having the inotropic effect, remember a positive inotropic effect would be that the contraction was more pronounced. So now we have less ventricular contractility. So that makes sense that you might feel dizzy with it. Contraindications include hypersensitivity, cardiogenic shock, second or third degree AV block, and non-life-threatening dysrhythmias. Now let's look at the class 2, and these are beta blockers. They reduce or block the sympathetic nervous system stimulation, thus reducing transmission of impulses in the heart's conduction system. They depress the phase 4 depolarization and are general myocardial depressants for both the supraventricular and ventricular dysrhythmias. They're also used as anti-anginal and anti-hypertensive drugs. So we've seen these drugs before. A drug that we would see in this case, though, is atenolol. It's a cardioselective beta blocker. It preferentially blocks the beta 1 adrenergic receptors that are located primarily in the heart. It's also a non-cardioselective beta blocker that blocks not only the beta 1 adrenergic receptors in the heart, but also the beta 2 adrenergic receptors in the lungs. So therefore it can exacerbate pre-existing asthma or chronic obstructive pulmonary disease. Its uses are antidysrhythmic, hypertension, and angina. Contraindications include severe bradycardia, second or third degree heart block, heart failure, cardiogenic shock, or a known hypersensitivity. In the class 3 drugs are amiodarone, dronedarone, dofetildiol, sotalol, and ibutylid. These increase the APD. They prolong repolarization in phase 3, and they're used for dysrhythmias that are difficult to treat. Life-threatening ventricular tachycardia or fibrillation, atrial fibrillation, or flutter that's resistant to other drugs. Amiodarone markedly prolongs the action potential duration, that is the APD, and the effective refractory period, or the ERP, in all cardiac tissues. It blocks both the alpha and beta adrenergic receptors of the sympathetic nervous system. It's used for one of the most effective antidysrhythmic drugs for controlling supraventricular and ventricular dysrhythmias. Its indications are for the management of sustained ventricular tachycardia, ventricular fibrillation, and non-sustained ventricular tachycardia. It is the drug of choice for ventricular dysrhythmias according to advanced cardiac life support guidelines. The adverse effects of amiodarone include corneal microdeposits, which may cause visual halos, photophobia and dry eyes, photosensitivity, and pulmonary toxicity. So you would want the room to be low light for somebody who's receiving amiodarone. Drug interactions include digoxin and warfarin. Contraindications are hypersensitivity, severe sinus bradycardia, or second or third degree heart block. The class 4 drugs are calcium channel blockers. They inhibit the slow channel or the calcium-dependent pathways. They depress the phase 4 depolarization and reduce the AV node conduction. They're used for paroxysmal supraventricular tachycardia, or PSVT, and rate control for atrial fibrillation and flutter. Diltiazem is used for the temporary control of rapid ventricular response in patients with atrial fibrillation or flutter and PSVT. Their contraindications are hypersensitivity, acute myocardial infarction, pulmonary congestion, Wolff-Parkinson-White syndrome, severe hypotension, cardiogenic shock, sick sinus syndrome, or second or third degree AV block. So looking back at all of the antidysrhythmic drugs, the contraindications to their use include known drug allergies, second or third AV block, bundle branch blocks, cardiogenic shock, sick sinus syndrome, and any other ECG changes depending on the clinical judgment of a cardiologist. Other antidysrhythmic drugs would mean that we wouldn't want to give these on top of them. All antidysrhythmic drugs can cause dysrhythmias. And these can be as a result of hypersensitivity reactions, nausea, vomiting, diarrhea, dizziness, headaches, blurred vision, and prolongation of the QT interval. When we look at drug interactions, if your patient is on Coumadin, we want to monitor their international normalized ratio, also known as the INR. We also want to make sure that if they're on amiodarone or disopyramide or quinidine, that they're not drinking grapefruit juice. Adenosine is one medication that is an unclassified antidysrhythmic. It slows the conduction through the AV node, and it's used to convert PSVT to a sinus rhythm. It has a very short half-life, less than 10 seconds, and it's only administered as a fast IV push. And when I say fast, I mean fast. And it may cause asystole for a few seconds. Other adverse effects are minimal. So what happens with PSVT is that you have an extremely fast heart rate. Even babies with PSVT have a heart rate above 200. And this isn't long enough for the ventricles to fill because the heart is beating so fast. So people will feel lightheaded, they may pass out. There's a lot of things that go along with it. So when they're in this rhythm, one way that we get them out is to put cold on their face. And when I say on their face, I mean over their eyes and nose and on basically from their forehead down to their chin. Ice cold water will sometimes get them to convert out of PSVT. Another thing that we can do to get them to convert out of PSVT is to get them to Valsalva by increasing their intrathoracic pressure. That doesn't seem to work as well as the cold does, but those are methods that we can get them to come out of PSVT. If those methods don't work, then we give them adenosine. And adenosine, like I said, is given very fast. I mean, you are pushing it as fast as you can push it. So what happens is when it acts on the conduction at the AV node, the heart stops. It is the weirdest thing that you will ever see because they will get a flat line on the monitor for several seconds. And the person is awake and they can see this flat line on the monitor. And then all of a sudden, the heart rate will start back up again and you'll see a normal rhythm at that slower rhythm that we should be seeing. It's really kind of an amazing drug. Another question for you. A patient has received a dose of adenosine and almost immediately the heart monitor shows asystole. What should the nurse do next? Check the patient's pulse, prepare to administer cardiopulmonary resuscitation, set up for defibrillation, or D, continue to monitor the patient. Well, like I told you, this is what we expect to have happen. So we would D, continue to monitor the patient. The half-life of adenosine is very fast, only 10 seconds, and the asystole only lasts for a few seconds. The nurse should continue to monitor the patient for therapeutic and adverse effects of the medication. So now let's look at the implications of these antidysrhythmic drugs. We want to obtain a thorough drug and medical history. We want to measure the baseline blood pressure, the pulse, their INO, and cardiac rhythm. We want to measure serum potassium levels before initiating any of the therapy. We want to assess for conditions that may be contraindications for the use of specific drugs, assess for potential drug interactions, instruct patients to report dosing schedules and adverse effects to their physician, and assess plasma drug levels as indicated. During therapy, you want to monitor their cardiac rhythm, their heart rate, blood pressure, general well-being, skin color, temperature, and heart and lung sounds. You want to monitor for toxic effects and instruct the patients to take their medications as scheduled and not to skip doses or double up for missed doses. Instruct the patients to contact their physicians for instructions if a dose is missed. Instruct them not to crush or chew oral sustained released preparations. Another question. A patient is in the emergency department with an unspecified supraventricular dysrhythmia. The physician orders a dose of diltiazem IV push. While the nurse administers the medication through the IV lock, the patient says she feels something wet spilling on her arm. Her heart rate was unchanged. What will the nurse do next? A. Assess the patient for diaphoresis. B. Check the IV lock to see if it is functioning properly. C. Repeat the dose of diltiazem. Or D. Start the IV in another location. Well, the correct answer is to check the IV lock to see if it's functioning properly. Because the heart rate was unchanged and the patient felt fluid on her arm, the IV lock was probably not working properly. Before anything else is done, the IV lock should be checked for proper functioning. Another dose would be wasted if the IV lock was not working. And if the IV site was a good site, even though the IV lock wasn't working or put together properly, sticking the patient a second time would not be a great thing to do either. A patient is receiving oral quinidine. Which assessment finding is of most concern? Nausea, prolonged QT interval, diarrhea, or occasional palpitations? The answer to this one is B. Patients taking quinidine need to be monitored for prolonged QRS and QT intervals, which may be a precursor to more serious dysrhythmia problems. A prolonged QT interval can make it possible for the T to be out there so far that the P comes along and hits it, putting the patient into ventricular fibrillation. So we want to make sure that our patients are not having prolonged QT intervals. Other implications include monitoring the ECG for prolonged QT interval with use of antidysrhythmics, including amiodarone, procainamide, quinidine, diphenhydramine, bipridine, sotalol, and flecainide. Administer IV infusions with an IV pump. Solutions of lidocaine that contain epinephrine should not be given IV. They are to be used only as local anesthetics. So you've got to make sure that the lidocaine that you're giving IV is a lidocaine only solution. You want to ensure that the patient knows to notify the healthcare provider of any worsening of dysrhythmia or toxic effects like shortness of breath, edema, dizziness, syncope, chest pain, GI distress, blurred vision, or edema. Finally, we wanted to teach the patients taking beta blockers, DIG, and other drugs how to take their own radial pulse for 1 full minute and to notify their physicians before taking the next dose if their pulse is less than 60 beats per minute. We are going to monitor for therapeutic response, which should be decreased blood pressure in hypertensive patients, decreased edema, decreased fatigue, regular pulse rate without major irregularities, improved regularity of the rhythm, and improved cardiac output. And that's it about these different antidysrhythmic drugs.